Uh, a very good afternoon to one and all of you. I know we are closer to lunch, and this is just a 7-minute video of very simple issues which most of us do similarly. And I'm just going to reiterate those important things about doing cataract surgery in hypermature cataracts. Now, so this is a hypermature cataract, as we can all see. Just a tiny nick has been made, and the liquid comes out, white liquid. But this is not an intumescent cataract. We need not be alarmed. We can just empty it, deflate it, so that the lens iris diaphragm moves backward, and there is no rhexis extension. However, you can go ahead and create a larger rhexis in these particular cases. And once that is done, the plan of action is different here. I bring the hard nucleus up into the anterior chamber. The challenge here in hypermature cataract is there is no epinucleus, and the zonules can be quite weak. So I do not want to challenge this eye. So I inject an IOL scaffold into the capsular bag. And I would like to do a vertical chop in these cases. This surgery is practically being done in anterior chamber. So I would repeatedly go back and just inject a dispersive viscoelastic and eat up this nucleus. But I have, in this particular case, managed a flaccid PC bothering, or the zonules getting weaker. Now this has more intumescence. As you can see, there's more viscous cortex here. So initiated through going through the side port with the microforceps, in small nick only has been created, but the rhexis has started extending. These eyes were preoperatively, mannitol was given, all the precautions were taken. However, having said that, although the decompressive efforts were done, the rhexis has extended. So I go on to the next pillar. My attempt is that I try to create some form of rhexis. Although the rhexis has extended significantly, herein again I see that the rhexis has started to extend. So I stop, go ahead, go and make a nick, the last venture here, to make a small nick and round off the rhexis to whatever extent which is possible, although there are 3 areas of weak points here. Now I go ahead and open the anterior chamber and make my incision. It's very critical that there should not be too much lateral separation. There should be only vertical chops being done, no stop and chop in this case. After having removed the nucleus, inject viscoelastic. Keep ensuring that you inject viscoelastic before you remove the instruments, because any of these weak areas can extend and you can be totally jeopardized. And finally, when you place your 3-piece lens, ensure that the haptic of the lens is covered by the area where there is some amount of rhexis, and complete the case. Now there's a third case. Again, it can present the fibrous capsule. Again, just a small nick has been made, and just a small liquid, milky fluid comes out. It's not that it's going to extend here. So I go in again, deflate the anterior capsule so that it gets totally flattened and does not have a convex configuration. And now the plan of action is to create a rhexis, then take the rhexis with the microforceps beyond the area of fibrosis, so that it's about 5 to 5 millimeter rhexis which is being created. I keep going back, gripping at the beginning of the rhexis at every point, and create a generous 5.5 millimeter rhexis. Now again, now I go and open the incision. The idea in all these cases is to not have anterior chamber fluctuation, keep the AC maintained at all times. So now it's a mobile nucleus, no epinucleus. So I try to create a small trench so that I try to get a hold of this nucleus. I start approaching it, but again the nucleus rotates. But there comes a point of leverage wherein you have got it, and then you start doing your horizontal chop. The nucleus is partly in the capsule and capsular bag, and partly as you go on to separate the nuclear fragment, it comes nearly into the anterior chamber. So again, you have to keep injecting dispersive viscoelastic intermittently, but whenever you do that, you get your one instrument out, and then finally deepen the anterior chamber with enough viscoelastic. When you're getting to the last fragment, bring down your phaco parameters, because that's very, very critical, because any time the posterior capsule can get trampolining into the phaco probe. And also keep in mind that the zonules are weak. So having told you again and again some of the very important features which we need to take care in these hypermature cataract, this is the last case which I'm going to do. All the theory aside, things do not work as we want. So I make my small nick. Again, there is fibrosis in the mid-periphery and in the periphery too. So the plan is to make a rhexis which comes within the area of fibrosis, so that I believe that I could make a small opening, not as large as was made in the earlier cases. But see, it just did not happen that way. I go back and inject viscoelastic and flatten it. Again, try to approach the other side to ensure that I go ahead and somehow complete the rhexis. I might have a small flap, is what I thought. But again, at that juncture, when there is fibrosis, I'm stuck and I have a fairly large flap. So I decide that I'm not going to deal with this flap at this point of time. I'm going to push it aside. I just do a good gentle hydro. There's not too much hydro which is needed in these hypermature cataract, because there's hardly any cortex to have corticocapsular adhesions, which is what you're trying to separate when you're doing a hydro. So I just rotate the nucleus and I'm clear that I'm going to get this nucleus out into the anterior chamber, because there is this one big weak point there which can create a wraparound rhexis, which was being alluded to in the earlier talk of rhexis extension. And I go ahead and chop the cataract into multiple small pieces, always ensuring that I keep my phaco probe right in the center of the pupil. I ensure that my parameters do not go high. I keep injecting viscoelastic to push back the phaco posterior capsule, because all said and done, while I'm intent on eating up the nucleus and trying to protect it from the cornea, it shouldn't happen that the posterior capsule comes forward and gets into the phaco probe. Now I have this small shell of epinucleus, which looks more like a Sommering's ring in this particular case. So I go back, inject viscoelastic, push back the PC, and try to nudge with my dialer to get this small piece forward and eat it up. So much of the challenging part of the surgery is done. And once this epinucleus is eaten up, I inject viscoelastic. And now I'm going to inject my IOL into the capsular bag. And this is again a 3-piece IOL which is being injected. And as I said, I would always ensure that I unfold the 3-piece IOL very gently into the bag, so that there's no rhexis extension which is occurring, which has already occurred. And finally, just to give it a completion, I make a nick in that very large flap and then turn it around and make it into a fairly decent rounded rhexis, although because the other parts of the rhexis are quite fine. And then remove all the viscoelastic, hydrate the wound, and close the case. So this is just a cluster of 4 cases which I wanted to show you all, so that we understand what are these minuscule challenges we face when you're dealing with a hypermature cataract, and a hard one at that. Thank you very much.
Thank you, Dr. Chitra. Excellent surgeries done, and excellent difficult scenarios and the way out of it. Dr. Chitra, can you join us here? And we come to our last talk. I know our glaucoma colleagues are getting restless, and we'll quickly sum up this talk. But this talk is a very important talk, especially important because it's going to be given by Chairperson, Scientific Committee of West Bengal. Thank you very much, Sudipta, for being with us today.
Thank you, sir, for the kind introduction.